Good afternoon and welcome to the George Washington University School of Public Health Bioethics Interest Group Ethics in Public Health webinar series. We're very lucky today to have two experts in organ transplantation with us, Dr. Mohammed Mohiuddin and Dr. Lint Johnson. Dr. Mohiuddin is at the University of Maryland and Dr. Johnson is here at George Washington University. We are going to hear from Dr. Mohiuddin first, and then Dr. Johnson, and then we will move on to some Q&A. So please put your Q&A into the chat, and let's go ahead with Dr. Mohiuddin first. Thanks so much for coming.
Thank you very much. I'd like to share my slides first. And please let me know if you can see one slide.
Yes, that works.
Okay, good. Thank you very much for this opportunity.
We see two slides at this point. There are two slides on.
Okay, again. Okay.
There we go.
Great. Thank you very much. My first disclaimer is that I'm not an ethicist, but have dealt with the issues pertaining to xenotransplantation a lot, and I will kind of try to explain what we have faced. I always start with the two patients that we have recently have done surgery who were kind enough to participate in this experimental procedure of xenotransplantation, where they received genetically modified pig hearts. It was the courage of these patients who kind of knew the outcome of these surgeries, but still wanted the science to progress and us to learn more from it. Their families also were very helpful, not only during the recruitment process, but during the surgery, post-surgical period, and even after these patients who have passed away. And these people have been our spokesperson at many different meetings. So I just wanted to explain that these patients have consented to this procedure. They were well aware, they had full psychiatric evaluations before they consented to this. So we all know that there's a long waiting list. The kidneys, the waiting list has the highest numbers. However, we have done very well over the years in terms of transplantation. The outcomes have improved. However, the waiting list keeps going up. And no matter what we do, we will not be able to overcome this disparity, and for that reason we need other alternatives. And there are many alternatives, and since I'm in the field of cardiac surgery, so I will highlight mostly the alternatives for heart. We are trying to regrow the heart in the petri dish, and we have mechanical devices, and there are Doris Taylor and her group is trying to decellularize the heart and recellularize it with their own stem cells. And the group in China has already grown organs in a non-human condition. So, however, all these are what I consider not competing but complementary techniques that will allow us to serve a larger community of patients who needs heart transplantation. However, what I would like to suggest here is that, since every 80 minutes someone dies because of lack of organ, I will suggest that, we can use genetically modified pigs to overcome this shortage. And why pig, right? I mean, we see that their anatomy is very similar to the human anatomy. They grow well in captivity, and they have we know the genome very well, so we can modify the genome, and that's what we are doing. I'll talk about it in a second. And they grow very fast. So the two cases we have done in humans, the pigs were only 1 year old. So within 1 year, the organ size is compatible with what we can use in human. The physiology is a little bit different. The blood pressure is 20 millimeters less in the pig, but that can be overcome with drugs. The pigs were chosen because we thought that there are approximately 90,000 pigs sacrificed every day for the dietary purpose, and we thought that may not raise as severe ethical issues as other animals. So, however, there are several ethical issues related to this, and I'm thankful to Dr. Daniel Hurst, who's an ethicist at Rowan University, who's been very helpful in providing some of the slides to me, and we have been in constant contact, and I'm trying to learn more from him. So there are several ethical issues that are listed here, but I will, in the interest of time, only touch upon only the ones that are highlighted in red. So the public and patient viewpoint, right? So I'm also, I just got off as president of International Xenotransplant Association, and we developed this Changsha communique where we have collected a lot of opinions and compiled them in form of a communique. So we all agree that the regulatory system should be transparent, must include scientific and ethical assessment, and should involve the public. We have done multiple studies and looked at the perspective of xenotransplantation in many countries, and you can see the numbers here that that 41% in the United States are comfortable to use this for themselves. There are I'll talk more about the religious restrictions and how that affects the acceptance rate. In the U.S. National Survey, approximately 40% expressed discomfort with receiving a pig organ for themselves or a loved one. The major cause is there is lack of evidence of success, although as we speak, there are two kidney patients in the United States who are living for more than the one done first is living for over 9 months with a pig heart, a pig kidney, and there's one in China who's living for more than 7 months at this time. So when we polled the different religious groups, I mean, there was some concerns. However, they all agreed that if we use these animals in a humane fashion and use them as the last resort, the religions allow it, and some of the religions even said that if you have an option to save life, and not using is a bigger sin than using it. But as highlighted here, the biggest thing was there is not enough evidence, clinical evidence available, and they were concerned about the risk of animal to human infections, and surprisingly, the concern about the religion permissibility was the least. So the animal rights and animal welfare, take the precedence in every case, right? So this is a heading that was in the Vox in October 21. Is it okay to harvest pig kidneys to save human lives? So this is an issue that mass popular media is picking up on and will likely get more attention with additional xenotransplantation studies when clinical trials begin. So So, and what are the animal rights? Right. So, when judging the acceptability, when judging the acceptability of the use of animals for xenotransplantation or for any other medical purpose, a decision must be made about whether the pain and suffering caused to the animal is justified by potential benefit to human health. One could accept the position that in some cases the saving of human life or significantly enhancing its quality might justify a certain amount of animal suffering, provided this is kept to a minimum. And there are the breeding and housing conditions, safe or of the quality that you can have the organs moved from there. There is some evidence that people have stronger negative reactions and greater moral concerns towards the use of primates. And that's why, initially primates were used as donors because they are much closer phylogenetically to us. However, none of those transplants lasted for longer. And then with the concern of transmission of disease like HIV, prevented further use of those primates. Primates also seem to have greater intelligence, emotions than human can identify with, look more human than other animals, and possess other traits that human can relate to. Nevertheless, there are main concerns about the use of pig as a source of organ, given their high intelligence, complex mental lives, and capacity for suffering. So one thing that we are coming across is like when these patients start to live longer, what are the risks to the bystander, third parties, and public health? Perhaps the most significant ethical issue associated with xenotransplantation is the risk of zoonotic diseases, non-human animals to human transfer or zoonosis. And this is not a hypothetical risk. In our first experiment, we found that the donor pig carried a porcine CMV virus, although it did not infect the recipient, but it did probably infect the heart that came with that was used as a donor and had some inflammatory reaction leading to graft dysfunction. So in the subsequent cases, both in our case and in other cases in the kidneys, nobody has found any viral transmission so far. So the perception has changed over a period of time. In the 80s and 90s, risk of zoonosis from xenotransplantation was potentially high. Now, the risk of zoonosis is thought to be low, manageable, but remains somewhat unknown without real-world clinical trial data. As we are approaching clinical trials, and this data will be available and we'll have more information. However, we know that even with allotransplantation, we deal with infections, and we've learned to overcome them. And as these clinical trials will progress, we'll probably have enough evidence or cases to study and deal with these issues. So modern research ethics guideline, as well as the research reviews by institutional review boards, IRBs, place an emphasis on the welfare of the individual participants. This does not mean that some risk is not assumed by research non-participants or bystanders. So there has been recent interest in ethical dimensions of risk to research non-participants who could be negatively affected, and how balance the cost and benefit of this implementation. So who are the bystanders? These are the general public, medical staff, family members, sexual partners, caregivers et al. Following allotransplantation, caregivers are often needed for household tasks, transportation to follow-up appointments, support for medically related tasks, medication adherence, of assistance with daily life activities, and wound or line care. Following xenotransplantation, the task would be similar, with additional concern of contracting novel zoonotic diseases. So the risks presented to caregiver could include risk of acquiring a novel pathogen from an animal source, stigma associated with acquiring a novel transmittable disease, guilt caused from transmitting a novel disease to others, violation of privacy and confidentiality, a possible infringement on their freedom if quarantine is deemed necessary because of signs of zoonosis. So it's still, this is an open debate. So we need an informed consent from not only from the patient, but from the people coming in contact with with these patients. And we will have to make sure that they understand the risk, accept the risk, and are ready to undergo regular medical surveillance. So the consent from bystanders, there are potential recommendations. The transplanted recipient has been educated on the responsibility to inform close contacts of possibility of infectious disease transmission. The onus is on the recipient to educate bystander of zoonotic disease risk. They have to worry about the potential violation of principle of confidentiality if close contacts caregivers are notified about potential zoonotic risk. Consent of third parties and just to the condition the right of patient to participate in clinical trial on the consent of third party. Close contact should be given an information sheet with consent of recipient due to the issues of partial confidentiality. Hospital, the staff and caregivers in direct contact with xenotransplantation should provide consent to potential risk. So right to withdraw. So since there's a considerable less risk involved with xenotransplantation of zoonotic diseases, so I mean, it was recommended in the earlier phase that the introduction of a new product whose ultimate effect are disputed, unknown, should be resisted or should only proceed with utmost caution. And lifelong or very long monitoring was recommended. Nuffield in 1996 also said that it should be made clear that consent to the operation also implies consent to subsequent monitoring. And the PHS guidelines also discusses that the importance of complying with long-term, lifelong surveillance. We were told by FDA to have the tissues kept for about 50 years, and this is being debated also. The participant selection also is important, and they should understand the consequence. So with the context of a clinical trial, should the xenotransplantation patient be subject to long-term, lifelong monitoring? The ability to withdraw from clinical trial is cornerstone of research ethics. So in seeking informed consent, the following information should be provided to each subject. A statement that participation is voluntary. Refusal to participate will involve no penalty or loss of benefit to which the subject is otherwise entitled, and the subject may discontinue participation at any time. How would mandatory monitoring be enforced? Pediatric patients, once the patient reaches the age of majority. I mean, I brought pediatrics because there's been a discussion of using the pediatric patients for this process. So this is the slide I started with, and we've touched upon some of the topics in the interest of time, and we can discuss more in the question answer section. With that, I thank you for your attention, and happy to take
Thanks so
questions.
much, Dr. Mohiuddin. That's very recent developments, and perhaps some of the people on the webinar have never even heard of some of them. Dr. Johnson, we're moving to Dr. Johnson now, who's the professor and executive director of the Liver and Pancreas Institute for Quality here at George Washington University. We're very happy to have him today. I also want to remind everyone that you can post questions in the chat. We have some questions that were submitted before the webinar, but we would be happy to have additional ones now. And after Dr. Johnson speaks, then we'll move to a Q&A session. And I'll be posting both of their bios in the chat so that you all can see how lucky we are. So thank you, Dr. Johnson.
Well, thank you, Dr. Goldstein, and thank you for having me. Coincidentally, for those who might have an interest in xenotransplantation, tomorrow morning, 7:45, we will be hosting in the Department of Surgery Grand Rounds with Dr. Robert Montgomery, who has been a pioneer in xenotransplantation and kidney transplants. So just coincidentally that's will happen tomorrow. But what I'd like to do is to share a little bit of a historical perspective and overview of the regulatory affairs in transplantation as it relates to ethical concerns, with a focus on deceased donor ethics, and lastly, discuss some of the ethical controversies in donation after cardiac death. So organ transplantation experimentation began in the 18th century, but it was only until 1954 that the first successful organ transplant was performed. That was actually a kidney transplant between two identical twins. At the time, we did not have known targeted immunosuppression. And so in order for transplants to be successful, it had to be from genetically identical individuals. And so that was in 1954. And then in the mid-1970s, cyclosporin, which became the first targeted immunosuppression to allow successful transplants to be performed on a larger basis, was discovered. Here are some of the other milestones. As I mentioned, the kidney transplant in 1954 in Boston. The first successful pancreas transplant for juvenile diabetes was performed in Minnesota in 1966. The first successful liver transplant was performed in 1967 by Dr. Thomas Starzl, who was at Denver at that time, but later on moved to Pittsburgh. And then the first successful heart transplant was performed by Dr. Norm Shunway in 1968. I believe that was performed at Stanford University. Nowadays, the more common transplant organs include the heart, as mentioned, but also pancreas, liver, intestines, lungs, and the most frequent transplant is kidney transplantation. So initially, when, as I mentioned, 1970, cyclosporin was developed, it was pretty much a free-for-all. That is that hospitals would have donors, and they would call the transplant centers, and there was no real system for allocating organs to recipients. And that was changed in 1984 when then Senator Al Gore from Tennessee introduced the act known as the NOTA, which was the National Organ Transplant Act, which created a national system known as the Organ Procurement Transplant Network to allocate and distribute organs throughout the United States. And this organ allocation system is operated under the auspices of the Department of Health and Human Services, which has given the contract to run this OPTN to UNOS for their entire existence. UNOS stands for the United Network of Organ Sharing, an organization run out of Richmond, Virginia. The only change that has been over the last several decades has been that the data registry for organ transplantations across the country has been removed from UNOS and given to an organization out of Michigan to operate. Under UNOS, there are 57 organ procurement organizations that are distributed throughout the country on a regional basis. And within those organ procurement organizations are hospitals where donors happen to be, and then also somewhere almost close to 300 transplant centers spread across the United States. As was shown earlier, even though that the number of donors has increased over the last decade, and that's been primarily through an emphasis on increasing donation, the disparity between the number of patients awaiting transplantation far exceeds the number of organs available by about a ratio of 6 to 1. And so some of the issues that have been dealt with ethically across the time that I've been involved in transplantation, which is now somewhere near 30 to 35 years, has been how should we ration these organs since we don't have enough for everyone on the waiting list? Should it be on a first come, first served basis? And when I first entered the specialty, that is exactly how organs were generally allocated. That is to say that a patient was put on a waiting list, and the patient who was put on the waiting list first had priority in the system. And we learned that that had a number of inequities as it relates to access to care. And that is that individuals who had more ready access to care would have first availability to get on a waiting list compared to other individuals who did not have that level of access. And so that became a discussion point as we revised some of the allocation policies. And then other questions that became pertinent included, should we allocate based upon the likelihood of success? And that is, we always want to balance this, the two facets of justice on one hand of the equation, but utility on the other hand of the equation as well. And so should it be based upon likelihood of success? Should we give organs preferentially to younger patients, patients who have fewer comorbidities? And to some degree, should we moralize disease? Should social factors weigh in? Should we weigh into when one person deserves over another person based upon whether or not their own life habits contributed to their end-stage organ disease? So in 1998, the Department of Health and Human Services adopted new principles for organ allocation. And there were broad criteria which included that each organ system had to have minimum listing criteria. That is to say, you had to have a minimum amount of organ dysfunction before you could be put on a waiting list. Also, you had to establish objective and medical urgency criteria when it was appropriate. And lastly, establish distribution units that will address urgency first with disregard to geography. And then the last premise was to increase organ donation by 20%. So one of the consequences of the federal government pushing OPO, Organ Procurement Organization performance, that is to increase the number of donors per population, led to the development of what was considered a secondary source of donors throughout the country. That is to say that traditional donors for organs were donation after brain death. And these are individuals that have irreversible loss of cortical brain function, but more importantly, they have loss of brainstem function. That is to say that they cannot breathe and maintain their organs through their own natural processes. And so these individuals who have an absence of brainstem function are declared dead. And that process was adopted by every state in the United States and was the way in which we procured organs for many, many years. There were ancillary tests that could be performed, including brain perfusion tests that look at blood flow, and the absence of blood flow to the brain was another area that would allow you to declare an individual was dead. The family would be approached, and if they consented to donation, that donor would go to the operating room. The organs would be allocated based upon the system that has been set up nationally. Well, there was a second form of donation that has now become acceptable throughout the country, and this is called donation after cardiac death or circulatory death. And so these individuals have overwhelming brain injury, but they do not fit the criteria in order to be declared brain death. And so many of these individuals have some degree of breathing impairment. They're all maintained on a ventilator. Most of them are also maintained by some blood pressure support. And so the family decides that they would like to withdraw care and allow those individuals to expire or die. In this situation, families can consent to donation. The individuals are brought into the operating room and the life-sustaining measures are removed. So the ventilator is removed, the blood pressure support is removed, and then the teams would wait until that patient expires. Occasionally, the patient doesn't expire within a certain time frame, and generally that time frame is somewhere within an hour. And if they don't expire, then those patients are not considered suitable for donation. They're taken back to the ICU with the family at the bedside, and then eventually those patients will expire over time. The problem is that there's only about an hour time frame between the time where a patient's blood pressure diminishes to the time when the organs are still satisfactory for use. And so just to reconvene, there are two methods, one being brain death, which has been our standard of donation, where there's irreversible loss of both cortical and brainstem function, and these individuals are declared dead before going to the operating room. And then there's a second category of overwhelming brain injury, but not enough to be declared brain dead, and those families decide to withdraw support. And if those individuals expire within an hour, then those patients can serve as donors, and that's known as donation after cardiac death. So there have been some ethical issues as it arises from this category of donation after cardiac death, and some of that is involved around when is death declared after circulation stops. That is to say, you don't want to go too early and risk of violating the dead donor rule, but also there is a time element in terms of how viable the organs will exist. And then there's some issues as it relates to what the recipient's information and the recipient risk. That is the quality of the organs and the donor outcomes with these DCD or donation after cardiac organs may suffer more damage than those that undergo transplantation from brain dead donors. And then there's new technology. One new technology is what's called normothermic regional perfusion, and that is the use of almost like an ECMO machine where individuals are placed on an oxygenator machine after they die to perfuse the organs and allow them to have less ischemic damage than they would be if they were placed in the cold storage. And that's typically done in the operating room for an hour or two to revitalize the organs. And then the other phenomenon that has resulted from this practice is what we call out-of-sequence allocation practice. That is to say, because there's this time element, many times the organs are allocated to individuals out of sequence. That is not the next individual who's most worthy, but perhaps the transplant center that is most willing to use an organ on any patient so that that organ gets used. And there are some consequences as a result of that. So there's some legal and ethical guardrails that I think that we all must employ in order for us to move forward through some of these controversies. Number one and the foremost is the confirmation of death. Everybody, I think, agrees on that. We also need to ensure the accuracy of that process and also the independence of the team determining death. There should also be a tight firewall between those individuals that are providing end-of-life care and the transplant teams that are procuring the organs for their recipients. And this is all pertinent to the webinar today and where we stand, because as we've mentioned, the transplant demand is rising faster than the organ supply. There's all of these new policy, equity, and new technology questions that are accelerating. And this really should not just be a clinical issue, but should be an issue that is discussed in the public domain as well as a systems issue, because by far the most important aspect of maintaining our success in our organ transplant system is maintaining public trust in the way in which we allocate organs, the way in which we treat donors, and the way in which we perform these procedures. So I thank you for your attention and look forward to participating in the question and answer session. Thank you, Dr. Goldstein.
Thanks so much, Dr. Johnson. And Dr. Mohiuddin. I'm excited to have all of the Q&A that's been going on while we've been speaking. And I think I'd like to start off with a question that was submitted prior to today's session about NRP. And my question really is about the number of these devices that exists, how common they are, how expensive they are, what does it mean in terms of allocation across the organ transplantation system? And do all organ transplantation programs have access to this technology? How many organ transplantation programs, in general, I'm sure, we don't have to have an exact number across the country. Where are they? Large urban centers, that sort of thing. Like, what is the distribution?
So let me start, I guess, and I will say that NRP, which stands for the normothermic regional perfusion, which is generally used in these DCD donors, it has been a huge controversy, I think, over the last few years. Part of the controversy has to do with the idea of reanimating organs and the fear of reanimating the brain. And so I've mentioned that the process of doing this is actually placing the donor after they've died from cardiac death onto an ECMO machine. And Dr. Mehudin can talk more about this than I can. But basically, it's a machine that allows you to oxygenate and perfuse the organs. In so doing, the process that has been adopted is to clamp the blood vessels that go to the brain. And I think that is kind of part of the ethical dilemma and challenge that we face as it relates to this particular type of procedure. I would say that the use of NRP is spotty across the country. Some regions have dealt with it and dealt with the ethical issues and feel comfortable doing it, whereas other regions have not dealt with it in a way in which there's a consensus amongst the stakeholders. And so it's not been adopted universally across the country. But I'll let Mohammed speak a little bit more to that subject.
Yeah, I mean,
Thank you.
is definitely, has increased the donor pool, right? So, since the start of using the DCD organs, we have, helped more patients than before. However, as Dr. Johnson elaborated, there is a concern that, how do you define that? And also, if you all these procedures of reanimating the heart, I mean, how effective they are. I mean, so far some of the results are controversial. I mean, there are normothermic methods or cold ischemic methods which have different benefits or side effects. So I mean, the jury's still out. I mean, they still want to see more results. There have been some good results that have been reported, especially from in hearts, and let's see how this go on. I mean, for now, I think it's helpful, but there are still a lot of concerns associated with it.
Yeah, for liver and kidney, I mean, it clearly is preserves the organs in a very satisfactory manner, and so the organs function very well. But there is this ethical challenge that I think is most pervasive in regards to its widespread application.
Thanks so much to you both. For those of us who are more biologically challenged, so we're preserving the organs by use of these technologies, right, including ECMO. But what does physically, what does it do to the brain when you clamp off what is the challenge focused on, the ethics, when you clamp off those blood vessels?
So, generally speaking, the brain can only survive without oxygen for 2 or 3 minutes. And so most times that when there's a DCD donor, there is a pause between the time that the heart has stopped pumping blood until the time that the individual is declared dead and the organ procurement team can procure these organs. Generally speaking, that's somewhere between 5 and 7 minutes. The concern is that we're going into kind of no man's land when we've waited that 5 and 7 minutes, but then we now have started to give oxygen and flow back to organs. How will that have an impact? And because it is not known, I think that the technique of clamping the blood vessels was introduced as a way to ensure that there wasn't any mishaps in regards to the brain receiving flow when it should not be receiving flow. I don't know if that makes a lot of sense, but I think that became, part of the argument around why you should clamp those blood vessels.
Thank you. As I understand it, people worry that donors will no longer be dead. What does dead mean? What does brain death mean? Essentially, in current times, we know a lot more about what's going on in people's brains than we did 10 years ago, 20 years ago, with circulation of electrical pulses or hormones, things like that. So I think in my understanding, which I am not a doctor, so I want to put that out there. It is not a biological understanding. Reactivating organs, making them seem alive or usable in the person who's going to receive them, while we're preventing the brain from coming back, if that could even happen after 5 or 7 minutes. And that is what we call, I believe, autoresuscitation, but that's not the brain. That's the heart itself. And I guess that would be Dr. Mohiuddin. The autoresuscitation, what I've read is that we've never seen it come back after that period of time. But it is something that, as Dr. Johnson said, we're very concerned with the dead donor rule, with making sure that we honor that rule, that a patient, it sounds simple, but it's not so simple, that a patient is actually dead before transplantation.
Yeah, of course. I mean, that's the reason why we clamp the carotids, so the just so there is no chance. I mean, I think there is one study in like millions that there was reactivation of brain activity, but in most cases, we are confident that that will not happen. But again, there's possibility of that happening, so we try to avoid that.
Thank you.
You may have seen recently, over the last, I guess it's been about 2 months, the Department of Health and Human Services, for the first time in history, decertified one of the organ procurement organizations for practices that were felt to be on the edge of what was acceptable behavior, and that had some ethical concerns throughout the country.
Yes, I have seen that. I'll post the press release from HHS on the chat as well, which is very disturbing to all of us, and I think upset a lot of people. And those people that really believe in the necessity of transplantation, I think, are worried about people removing themselves from donor lists because of this fear. And I think this has always been part of the fear, that we don't have enough people donating. I saw that there was a question also in the chat focused on this, about what are the methods that we have of encouraging donation. As you all have been in this world for many, many years, and I saw Dr. Mohiuddin, you posted an answer as well, but I'm wondering if we talk a little bit more about that. in
Yeah.
your particular areas. And I know you transplant different organs, so
Yeah.
that is very helpful. Yeah.
No, I mean, so definitely, public awareness and recruiting more organ donors is helpful. But especially for heart, there's such a strict criteria for accepting these organs that even I don't know if I donate my heart, will it be acceptable for? That's why I wrote, if we have a perfect big heart, with that you don't have to worry about, the matching or, it's universally accepted, and then it will be a better option. I mean, in the same respect, when we polled a lot of, went to different countries and asked their opinion, a lot of Muslim and Jewish leaders, they raised concern about desecration of human body for taking the organs. So when they were given the option of a non-human source, it felt very attractive to them also, that you are not, as you may know, that in a lot of countries only you can only donate from a living related donor, and there is no brain dead organ policy implemented in these countries, and there are a lot of them. And not just because of religious, but because of their cultural issues also. So some, there are different areas that we have to, focus on.
Yeah, I think that the driver license campaign has been very important over the last many years, primarily because it allows the family to know what the individual wishes are. For many years, families were approached for donation and they did not consent because they never had a conversation with the individual. They're faced with, a situation where somebody has died unexpectedly and they didn't know, so they would not consent. And so the fact that this movement has, really perpetuated throughout the country, I think has helped families, understand, if they haven't had those conversations, which many haven't, what the individual wishes are, and are more comfortable consenting, having the knowledge, that this person had designated himself as a organ donor.
Thank you. There are a number of questions in the chat regarding consent, right? As you might imagine. For instance, Dr. Mohiuddin, you've seen questions about how can we actually predict into the future what we're going to feel later on about lifelong monitoring? Isn't that intrusive? Too much to ask? Things like that. There's another interesting question. Patients in need of organ priorities focus for short-term benefit. How can they foresee long-term risk, from a psychiatric perspective or psychological perspective? How do you understand that from the long term? There's also a specific question about NRP, Dr. Johnson, about people that have registered or have put on their driver's license that they want to be organ donors, have never heard of NRP, but now NRP exists. How do we alert the public to this change? What if do we need to go back to them and make sure they know about it before they consent just on their driver's license? Things like this. So I guess in general, the newer issues that have arisen over your careers about consent, how it has changed, do they seem to be fundamentally different questions, or are they basically somewhat the same? Thinking about people who are going to give their organs, thinking about bystanders, and you've already talked about family members. What are your thoughts in general about all of these issues and what we're going to face next?
Okay, Mohammed, you want to take that first?
No. So you start with the
Sorry,
NRP,
I know that's
and then
many
I'll,
questions.
yeah,
It's
yeah,
many
that,
questions in one.
Yeah, I apologize. I was trying to answer one of the Q&A questions, but So yeah, I mean, consent, I think it has to be an evolving process in the sense that as new technologies become available, we've got to amend and adopt the way we way we gather consent from both donors and recipients. And I think that that's something that has evolved over time, but I would caution to say that everyone approaches it in the same in the same manner. One of the areas that I personally have had some distraught about is that there's always a push in the transplant community for the programs that do the most. And it's almost like, medal of pride if you can go out and do the most, as opposed to really who does the best. And, the 30 some years that I've been involved in it, it has always kind of been something that has bothered me in the, in a way in which we discuss transplant centers, transplant volumes, and the care of patients. And it doesn't go hand in hand, and oftentimes other factors can come in and conflict, on an individual basis, what's best for the individual over this drive to do the most. And that's something that I think from an ethical standpoint that we have not dealt with in the transplant community as we should have and could have over the years.
Yeah,
Thank
in our case, there's a fear of unknown, right? There's a lot that's unknown in xenotransplantation. We don't know, and zoonosis is one of the major factors. So, I mean, so what we have tried, our consent is very different from what we offer to our allotransplant patients. It's much more extensive. It involves consent from all the people involved. Even a person who's coming to pick up the garbage from the room has to give a consent that he understands that the room he's entering, there's a potential of transmitting some disease, of an unknown disease. So it's the same thing, applies for the immediate contacts and all that. So like Dr. Johnson said, that this is an evolving process. There's a lot that we don't know about, what kind of diseases or complications we'll face, and the drug treatment is a lot different in xeno versus allo. So what those drugs will cause in the long term. So I think this will keep evolving. And we try to make it as comprehensive. The concept, I mean, our consent is like now about 10 pages, and so we, as I described in these in the chat, that we make sure that the person and the family understands what they are agreeing to. They get multiple psychiatric evaluations to make sure that they're competent enough to give that consent. So, but again, it's a new field. It's evolving, and we'll have more questions than answers.
Thank you. I think we have time for one more question. Is there anything else that the two of you would like to focus on that you didn't have time to address in your initial comments?
So, I mean, the one thing that I will stress that that by xenotransplantation is that we don't want to completely forget allotransplantation. The choice will always be a human organ first, until if we developed a pig organ, which is where we don't need any immunosuppression, and that will be applicable to everyone. But we are very far from that point. But every patient that we have we have interacted with and have offered this treatment, we said that even if there's a chance that if this organ fails, the big organ fails, and if you become eligible for an allotransplant, that will be a possibility in a later time. So an allotransplant will always take precedence over any other other methods that we are developing.
Thank you. Dr. Johnson, any final summary points for our audience?
I don't think I have any summary points, but I do believe that transplantation is a noble field. I also believe that individuals that donate are really heroic, and both live donors and deceased donors. And it is a life-saving procedure that when it's done properly, which most of the times it is, I can't say that it's done properly 100% of the time, but most of the time in this country it's done well. It does provide a life-saving opportunity for individuals to have a productive life.
Thanks so much. There's so much knowledge in this field between the two of you, that we really appreciate it. We're very lucky to have been able to speak with you today. So
I see that there are a lot of questions that we have not addressed. I mean, if you'd like, you can
yes,
send those questions to us, and we'll try our best to, answer them to the best of our ability.
that's fantastic. That's exactly what I was going to ask. If you're open, we will send these questions to you and we'll send them back to our people. I do want to share a little bit more about our next. Could you move it to the next screen? Thank you. So we will be discussing pharmacoeconomics and drug pricing next month on November 18th. And we do have an in-person series as well here at GW. Artificial Intelligence and Research Integrity will be our in-person meeting on the 4th of November. We want to thank you all again for your participation. We had around 140 people at our max today. And thank you from me. I'm Professor Goldstein from the Department of Health Policy and Management with a bit of a legal and ethics perspective. And thanks so much, Dr. Mohiuddin and Dr. Johnson. And I really hope to meet you both in real life one day to get to discuss in more detail. So thanks to everyone. And that's our webinar for today on new ethics issues in organ transplantation. Take care and bye-bye.